Bloodborne viruses are a serious threat to health, and rates are high among people who inject drugs. Testing is the first step to treatment and preventing transmission, and vaccination can protect against hepatitis B. The WHO and the PHA have set out elimination strategies for hepatitis C. The aims of this audit were to evaluate our achievements to date with BBV testing, vaccination, and engaging patients in specialist treatment, to catch up where we'd fallen behind due to the cancellation of face-to-face services during the first wave of the pandemic, to maintain our focus to this health threat and play our part in elimination, and compare performance of our service with the national performance standards for the Orange Guidelines 2017 and Nice Quality Standard 23. All patients open to our core OST service in Belfast were audited. This service manages the most chaotic patients, with more stable long-term patients moving out of this clinic. Data was collected from October 20 to February 21, and the number of charts identified was 248. A retrospective paper chart review was undertaken, with outstanding information being sought from other services such as electronic care record and other services. Data was recorded using Microsoft Excel. Where information was incomplete, this was identified to the patient's key worker for follow-up. Our rates of BBV testing were strong, with 93.5 patients ever having testing. 65.3 was in the last 12 months. In 2017, when last audited, only 20.5 had testing in the previous year. Our service has benefited from the improved accessibility of dry blood spot testing. More work is needed to achieve timely HPV vaccination. Over 97% have been offered HPV vaccination, yet only around 59% received at least one dose. The UAM rate is higher at 71%. Detected HIV prevalence was around 3 times higher in our service population compared with the UAM survey, and more than double the rate in our service sample population from 2017. However, 100% of patients living with HIV in our service are engaged with treatment in GUM services. Given this increasing rate of detection, improved communication and liaison with GUM services has been a priority, and a weekly mutual user MDT meeting has been running. Overall past exposure to HCV was lower in our service population than the UAM rate, but had risen slightly since 2017. However, our rate of ongoing active hepatitis C infection was higher than nationally. This suggests that HCV positive patients in our service are not engaging successfully in treatment as readily as nationally. We have therefore sought to improve access to treatment for HCV by setting up an in-house assessment clinic run by one of our nurse practitioners. Here are my references. Many thanks.
Hello, my name's Mariam, and this poster is titled Trauma-Informed Spaces in Substance Use Treatment Services. There is a high rate of trauma exposure in individuals who use alcohol and other drugs. However, few studies have explored how the key principles of trauma-informed practice influence the physical spaces within the treatment services and the perspectives of the service users themselves. This study distributed questionnaires and asked participants about the physical spaces in the building, such as the waiting room and meeting rooms. The sample consisted of 24 service users, 1 carer, and 11 staff members. The data was then analysed using descriptive statistics. So here are the key service user results. So linking back to the key principles, firstly, safety. So a lot of the participants expressed that they did feel safe. And also they were happy with the amount of privacy that they had. Secondly, the principle of empowerment. So the information on display in the reception, some participants commented that they found it very useful regarding support groups available and information about psychosis. Lastly, the principle of choice and collaboration. So we got service user feedback about how to improve the service, specifically the meeting rooms and waiting room, and artwork and decorative cushions was suggested. Okay, so here are the staff results. The key result here is that staff felt that they couldn't access calm spaces in break times. This is important as practitioners working in substance use treatment and with clients who've experienced trauma, they're vulnerable to experiencing vicarious trauma. So key to trauma-informed practice would be to prevent this, thus calm spaces are important for staff well-being and work effectiveness. Secondly, it is important to consider previous research that has evaluated the effectiveness of trauma-informed environments on service delivery. For example, Goylitz and Kahn found that introducing pleasant smells into the physical space was associated with service user reduced anxiety and improved mood. Thank you for listening.
Hello, my name is Ita Contrin and I'm a research analyst in the Health Research Board in Dublin. Today I'm going to talk about a study on treated problem gambling. International evidence shows that treatment uptake for problem gambling is low. There is limited information on problem gambling in Ireland and there have been calls to record information more frequently and in more detail. Although information is recorded as part of a prevalence study, there is limited information on treatment of problem gambling in Ireland at a national level. The aims of the study were to better understand treatment uptake, to provide a profile of cases accessing treatment for gambling in addiction services in Ireland using routine national treatment surveillance data, and also to provide evidence which could be used to inform service policy and planning. We undertook a secondary analysis of data collected by the National Drug Treatment Reporting System. Included were cases who entered treatment for gambling between 2008 and 2019 who reported gambling as their only main or secondary problem. NDTRS data coverage is high. Completion for problem gambling is optional for service providers and it is likely that the number seeking treatment has been underreported. Between 2008 and 2019, 2,999 cases who entered treatment reported gambling as a problem. Problem gambling frequently co-occurs with other problems and almost half reported additional addictions. The majority of all gambling cases were male. The median age of treatment start was 34 years. 1/5 were living with dependent children. The median age first gambled was 17 years. 7% were homeless and there were high levels of employment and formal education qualifications. The majority were treated in inpatient settings and the median wait time to treatment was 6 days. The most common source of referral were self-referrals and very few cases were referred by health professionals. For those who reported gambling and additional addictions, the most common co-occurring problems were alcohol, cannabis, cocaine and benzodiazepines. There were significant differences between those who presented with gambling only and those with gambling and additional addictions for inpatient treatment, unemployment, living with dependent children, homelessness and source of referral to treatment. This is the first national Irish study using routinely gathered health surveillance data to describe treated problem gambling in Ireland. It is possible to collect data at a national level for treated problem gambling use and there is scope to extend the national system further for behaviour addictions. There were significant differences between those presenting with gambling only and those with gambling and additional addictions, and knowing the differences between these groups is important for different treatment requirements. Thank you.
This piece of work is a review of the first 6 months of a residential drug stabilisation service. The stabilisation service in Glasgow is a 10-bed facility offering a 6-week stay primarily for individuals on opioid substitution treatment or OST, with a focus of addressing harmful drug or alcohol use through interventions such as benzodetox or maintenance, OST optimisation and a wide variety of health supports. Initially the service was accessed through a stay in hospital or another project, but this evolved to direct access from the community. Match standards are an integral part of care in the stabilisation service. A primary focus is ensuring OST is optimised to maximise the benefits of treatment. An early recommendation from the Drug Death Task Force due to rising drug deaths linked to street benzo use was the use of residential placements to stabilise and establish maintenance benzo prescribing if appropriate, something which is offered by the project. Outcomes were measured for the first 6 months of direct admissions and taken as 3 months post-discharge. All treatments were offered equally and all appropriate interventions were considered. During the first 6 months, 33 people were admitted directly to the project from the community. 3/4 of them completed their planned 6-week stay. All of them either maintained or optimised their prescribed OST. Of the admissions, 42% were discharged on a maintenance benzo treatment prescribed in each case to stabilise high-dose street benzo use where significant harm was evident. There was a reduction in reported drug use of over 65% 3 months post-discharge, with IV use cut by more than half. There was a statistically significant increase in engagement in structured activities post-discharge, with many people choosing to become involved with recovery, employment or educational supports. An unexpected result was found when examining non-fatal overdoses. There was a slight increase in this post-discharge, but more notably the cohort involved was different than those who had overdosed pre-admission. Early analysis has found that the post-discharge group were 4 times more likely to have had a history of IV drug use before admission and were twice as likely to have been started on benzo maintenance. In conclusion, the stabilisation service was found to be effective in optimising OST, reducing drug use and increasing structured activities. Further analysis is required of the non-fatal overdose finding and outcomes should be measured again at 6 months. Thank you for listening and I'm happy to be contacted with any queries.
As many as 85% of people in contact with drug and alcohol services report traumatic experiences, whether as a precursor to or a result of substance use, so the relevance of trauma to this client group should be clear. The moving on after trauma or MOTE intervention is part of the first phase of the trauma treatment pathway and focuses on normalisation, psychoeducation and providing distress management skills. The MOTE intervention was adapted by the Avon and Wiltshire Mental Health Partnership from its original use with asylum seekers and refugees by instead exploring how the content related to substance use behaviour. Individuals were sent 6 videos to watch alone once a week with regular telephone check-ins. The use of video as a method of delivery was novel. This allowed more service users to be seen as it required less staff time and resources, reached individuals who would not have been able to participate in a group otherwise, and bypassed COVID meeting rules. Between January 2020 and August 2021, 34 referrals were made. In total, 14 were sent videos, 9 of whom began watching, and of that only 2 finished each video. A survey was also sent in March 2021 to all service users referred, made up of 5 open-ended questions to determine the impact of MOTE and to request ideas for improvement. Only 2 service users responded, and both were positive and indicated the intervention was informative and helped them live in the present rather than the past, though it is acknowledged that this is ungeneralisable due to the low response rate and volunteer bias created, as only the service users who finished the intervention responded. However, service users did give informal feedback during the telephone check-ins, and those who began watching the videos reported the experience as very validating. Although multiple service users did express a preference for being able to perhaps stop and discuss the content. High dropout rates are expected with this client group, but certain characteristics of PTSD would theoretically have made treatment from home more accessible. As the average completion rate for those sent the videos was 46%, it's important to consider barriers to engagement. Perhaps the pre-recorded nature of the videos and the lack of face-to-face check-ins removed the social connectedness from the intervention and created a lack of real-time personalisation of content. Some individuals found the videos too distressing, suggesting a need for more prep work, while others cited life getting in the way. In their assessments, many individuals expressed worry about what may be brought up, and fear of re-traumatisation is a frequent barrier to engagement, which may have been the case here, even though traumatic events are not directly discussed in the intervention. Overall, this suggests that the adaptation of the content of the MOTE intervention for substance use service users was appropriate. However, the method of delivery may not have been the most effective for various reasons, though the importance of not only offering trauma-informed practice, but direct trauma intervention is clear. The moving on after trauma or MOTE intervention is part of the first phase of the trauma treatment pathway, intending to stabilise service users and provide them with the groundwork to allow progression to further treatment if they wish. The prevalence of trauma exposure in people who use substances is high, and many go on to develop clinically significant PTSD or complex PTSD symptoms. Importantly, these symptoms of trauma can also maintain substance use and complicate recovery. Consider the self-medication model and emotional dysregulation seen in many service users. People who are using substances face a barrier to accessing mental health support, despite best practice guidelines. Therefore, it's vital to recognise why services should offer treatment for trauma where participants are not required to be abstinent. This intervention was adapted and shortened by the Avon and Wiltshire Mental Health Partnership into a 4-week, in-person manualised programme, each session 2 hours long with 2 facilitators. Participants completed 2 scales to assess impact of trauma prior to the first session and then after the intervention. This is relatively new to the organisation, and so far 2 rounds of mixed gender groups have been completed, with a total of 10 service users and an attendance rate of 70%. Due to absences or participants wanting to wait before completing the end of intervention questionnaires, there's little quantitative data to report. However, feedback has been given by service users and is overwhelmingly positive. Service users repeatedly found that their behaviour made much more sense and they didn't realise the impact that trauma had on so many areas of their life. They also wish that they'd been given the information earlier and that the content were made available to all professionals, implying a strong desire to feel explicitly understood by staff. Additionally, the group format was praised as beneficial, and the setting allowed for normalisation of responses to trauma and validation between members. Furthermore, the intervention seemed to work as a beginning of the trauma treatment pathway, as service users commented that it would be great to do before counselling, and many felt they wanted to try individual talking therapies or other trauma treatments. For future consideration, it would be useful to continue adapting the intervention, incorporating feedback from service users to ensure its best quality. Furthermore, following up on service users who took part in the treatment could provide insights into the long-term impacts after individuals have the chance to process and integrate the information and skills into their routine. It may be especially interesting to explore how individuals experience later phases of the trauma treatment pathway, depending on whether they took part in MOTE or in other stabilisation interventions. This is an important step into understanding the best way to provide services for those affected by traumatic experiences in the substance use client group.
This presentation is titled Individual Placement and Support, also known as IPS. The aim of this research is to evaluate the feasibility and impact of utilising the individual placement support model within community substance misuse services. WDP is a UK-based substance misuse charity. IPS supports people currently or previously misusing substances to achieve paid and sustainable employment. IPS Into Work operates in 8 West London boroughs and involves providing participants with up to 12 months of tailored in-work support. Using data from January 2019 to May 2021, WDP have completed a quantitative analysis of outcome data and qualitative analysis of service user case studies. WDP have successfully established the recruitment of WDP IPS employment specialists, referral pathways with the Job Centre Plus, NHS, probation and rehabilitation services, partnership working arrangements with other substance misuse service providers, job brokerage and significant engagement with over 30 employers. The impact has shown us that there have been over 1,200 referrals, with 80% from drug and alcohol services, which has translated to over 750 engagements, 191 job starts, which showed us that we had a 36% job start rate, 76% went into full-time work and 24% went into part-time work, a 38% job sustainment rate at 13 weeks, and 73% reported increased health outcomes. There has been over 3,700 hours of support given to participants, and the key themes identified during the thematic analysis of service user case study included enhanced motivation, increased confidence, reintegration with society as a whole, and the development and improvement of both professional and social networks and skills. Our findings and conclusions have shown us that this evaluation shows that the IPS model can be successfully implemented within a community substance misuse setting, and that it has a notable impact on the service user employment engagement, outcomes, and experience. We aim to commission a larger scale external evaluation, and will utilise our expertise to advocate for the expansion of IPS through local and national government. Please see below the conflict of interest statement and ethical approval.
Hello, my name is Kathy and I work at the Health Research Board in Ireland. This study is titled Characteristics of Concerned Persons Accessing Addiction Treatment Services in Their Own Right, a secondary analysis of existing Irish health data for 2010 to 2020. Concerned persons are friends and family members affected by another's substance use and addictions. Estimated at more than 100 million worldwide, concerned persons play an important role in addiction treatment and recovery and are deserving of support in their own right. Concerned persons are a largely hidden population. Those who access services are in the minority, but may be among those experiencing the worst harms. The aim of this study was to describe concerned persons accessing services for support in their own right and to provide evidence to inform measures to address their support needs. The study involved a secondary analysis of data from the National Drug Treatment Reporting System, or NDTRS, which includes the only national data set on concerned persons. Included were data for all 13,477 referrals received from 2010 to 2020 and for 3,842 treated cases for 2016 to 2020. I will highlight some key findings. We found that 2 in 5 referrals were aged 45 to 64 years and that 7% of referrals were for children. Half of the child referrals were aged under 15 years. We also found that 4 in 5 adult referrals were for females. However, the child referrals were almost equally divided between males and females. Of the adult referrals, 1/3 were females aged 45 to 64 years. The majority of referrals were living in stable accommodation. Adults mostly lived with others. 2 in 5 were living with children. Most child referrals were living with parents or family. 1 in 10 referrals were for persons born outside of Ireland. Half of adult referrals were in employment, while 1 in 5 were unemployed. We also found that children were mostly referred through family and friends, however 1/4 were referred by social or community services. Adults mostly self-referred. Finally, we found that individual counselling was the most common treatment intervention. These findings can inform measures to support concerned persons. Among our key findings, around 1,200 referrals were received per year. The majority were for females and 1/3 were females aged 45 to 64 years. Notably, referrals included children and half were aged under 15 years. In conclusion, the figures underrepresent concerned persons nationally as recording of this data was optional and concerned persons may be accessing support elsewhere or not at all. There is scope for routine monitoring to include further variables on concerned persons. Finally, the NDTRS is the only national data set on concerned persons, and to our knowledge, this is the only study using data of this kind to describe the group. Please contact us if you would like further information. Thank you.
Written Outreach, an addictions liaison service for psychiatric inpatients. The Ritson Clinic in the Royal Edinburgh Hospital is a specialist addictions inpatient unit that has for many years provided advice and some liaison to other wards in the hospital. The purpose of this project was to set up and evaluate a more formalised liaison service to psychiatric inpatients with comorbid drug or alcohol problems. And this work is supported by several NICE guidelines and was also a response to the tragic rise in drug and alcohol deaths in Scotland in 2020. The referrals were made by email or phone to the team, which was consultant and trainee psychiatrists, charge nurse, and the pharmacist would provide advice. We gave same-day telephone advice. Face-to-face patient reviews depended a little on the time we had, but usually within 24 to 48 hours. We didn't have a specific resource, but our beds have been reduced slightly due to the pandemic, and we therefore had a bit of time resource to use for this service. And the focus was on ensuring rapid and safe prescribing for drugs and alcohol. The setting was the Royal Edinburgh Hospital, which is a general psychiatric hospital with the usual range of specialties, although not young people anymore. And the intervention was to pilot and evaluate this service. We kept a database of 79 referrals from September 2020 to June 2021, and this is ongoing. Some of the findings are shown here. There were more male referrals, 15 to 29. Most people were in general adult psychiatry, 65, with 9 in rehab, and smaller numbers in old age, forensics, and brain injury. More people had drug problems, 52, and 22 with alcohol problems, and 5 with both. Many of the patients had psychotic illnesses, and many were suicidal when they were admitted. We did a brief satisfaction survey to inpatient doctors in the general adult wards, who said that they found this service very helpful and hugely important, vital, and a good example of necessary liaison for complex patients. In conclusion, we felt this offered better links to community addictions follow-up services, which was greatly important, and better opportunities to manage both alcohol and drug misuse disorders, including the opportunity of initiating or continuing opioid replacement therapy and considering new developments such as injectable buprenorphine. It was also important to provide take-home naloxone, which can be overlooked in busy general adult wards. It offered the possibility of sharing of information, and in particular, of particular importance, teaching and training for students and trainees.
Hi, my name is Emma Smith, and I'm a third-year PhD student and associate lecturer at the University of Worcester. Today, I'll be presenting my research, which has been entitled Investigating the Experiences of Individuals in Recovery from Problem Substance Use and Their Perceptions of the COVID-19 Pandemic. There has been no conflict of interest in this research. I'll start by giving you a little bit of context. Isolation, discrimination, and feelings of powerlessness reinforce problem drug using behavior, whether through direct effects to mental and physical health or through indirect effects such as increased levels of stress. Because of this, it's been speculated that the coronavirus pandemic presents unique challenges for people with substance use disorders and their recovery, including greater risk of morbidity, decreased access to services, and experiencing increased strain on their mental health. This current research aims to explore how enforced forms of social isolation arising from the COVID-19 lockdown impacted instances of relapse, coping strategies, and how individuals engaged with harm reduction services. I'll move on to give you some context of the data collection for this study. So I was right in the middle of doing a photo voice research project with participants when it felt like out of nowhere, COVID-19 happened in March of 2020. Where I was planning on doing face-to-face interviews with participants, I had to be extremely ethically reflexive and decide how to continue with the data collection while prioritizing the well-being of participants. In March of 2020, during first interviews, participants volunteered information to me about how they had been coping during the COVID-19 pandemic. And during July of 2020, I made the decision to conduct second interviews with participants to ask them specifically how they had been impacted by social isolation. All participants in this sample were fairly new to recovery at the time of participation, with the majority having less than 6 weeks of recovery at the time of their initial interview. Results from the study present negative and positive aspects of the COVID-19 lockdown as it relates to participants' recovery. One participant, Lawrence, had quite a positive experience. He said, "A lot of us people in recovery have suffered anxiety in the past. So we're kind of in our element because it's like, yeah, welcome. This is how we feel all the time. I think it's really helped my recovery more than anything." This is in contrast to the experience of Kizzy, who said, "It's all very well self-isolating, but when you live on your own and you have mental health problems, at some point you're going to need human contact, and like face-to-face is just better." For this reason, individuals with a history of dependency should be considered potentially vulnerable to the effects of enforced isolation and should be supported accordingly. Just as individuals who are in recovery have heterogeneous experiences, so were their experiences during the initial COVID-19 lockdown. These are the references used for my study. Thank you so much.